All right. So good morning, everyone joining us today on this beautiful day. My name is Ruchika, and I'm a final year medical student from JJM Medical College, India. I'm very excited to share this interesting case with all of you. So I titled this presentation as Mirror, Mirror on the Wall, which is the most functional of them all. I would like to thank the whole team that worked on this case, especially Dr. Almeida, Dr. Reiner, Dr. Gupta, Dr. Otamendi for taking time off and for helping me put this presentation together. And thank you, Dr. Q, for allowing me to do this. So here we have a case of a 71-year-old right-handed Spanish-speaking male. He presented, he was previously normal, and he presented to the clinic with, he had sudden loss of consciousness and focal seizure, which was characterized by sudden speech arrest. After this episode, he was confused and he had speech difficulties, which lasted about 48 hours. And after 10 days, he presented to the Mayo Clinic. His neurological examination was normal. He was alert and oriented ×3. GCS score was 15. His external eye movements were intact. Pupils were equal and reactive to light. His speech was clear and articulate. Sensation was intact bilaterally to light touch. And his movements of extremities, he moved all extremities to command. He did not have hypertension before the seizure episode and developed that after the episode, for which he was put on telmisartan 80 mg once a day. To prevent further seizures, he was put on dexamethasone and on Keppra. So this is the pre-op MRI that was done. So on the axial T1 cut, we can see that there is an enhancing lesion present on the left temporal lobe. This focal hyperintensity is present in the superior temporal gyrus, and this we can see in the coronal T1 post-gyro section. There's flattening of the sulci and mass effect, which
Nancy Harden.
Indicating a diffusely infiltrating tumor with poorly defined margins. When we look at the T2 section.
I was just going to say, Ruchika, maybe since we have Dr. Sandhu here, maybe if you would like to add a few comments about this scan, we would appreciate that.
Yeah, no, it's as we go through the T2, initially the post-contrast T1 definitely shows the area of abnormal enhancement of left temporal lobe, would go along with some of his symptoms. She explained this really well with the iso-intense T1 signal, sulcal effacement, mass effect. You can see how the sylvian fissure is effaced there as well. So really want to look at the T2 weighted images, because if we think it's a primary glial neoplasm, there will be tissue that is also affected, which doesn't enhance, which we're seeing here on the, this is thin section reconstructed T2 and T2 flare, and you can see that that area extends beyond the area of enhancement within the insula and posterior temporal lobe.
Thank you. And when we compare the right side to the left side, so here we can see that there are sulci, and the sulci contain CSF, and CSF lights up on a T2 image. And this is absent here, again proving that the sulci is flattened. All right. So because of the proximity of the lesion to the superior temporal gyrus, which is very important for speech, and in particular, the primary phonological processing unit, a functional MRI was also performed. So we can see right here that the tumor is here. And here the patient has been asked to move his tongue. That was mapped. We can see these areas lighting up. In reading comprehension, here is where we have the speech center, and this is the lesion. So we know that it's a little, there's a distance between the lesion and that center. And here he was asked to complete sentences. And again, right here, we can see that this is the lesion and this is the center that lights up. So we know the lesion is at a distance. Dr. Sukhvinder, would you like to add something?
Yeah, no, I just going to say that this is where James in his talk he was talking about functional MRI. I think it's really important to understand how these images are obtained and how to interpret them. Exactly what you're saying. So basically, we're looking at 30 seconds of doing a task, 30 seconds of not doing a task, 30 seconds of doing a task, not doing a task. And we're looking at blood oxygen level dependent reaction in the brain. And what happens is that you take all that data and you statistically compare the on task versus the off task to see which areas have more activity. And then you can set the threshold of how specific you want to be in being able to identify which areas are statistically significant between on task and off task. So you can understand that, you know, if a patient moves or if they're not cooperating or they don't perform the task just right, there's all these different limitations, functional MRI. It's a beautiful technique, though, to see that we don't know if some of this is artifact that you're showing in the tongue activation. I think some of it, if you go up higher, there was a cingulate activation, maybe SMA was more of what we're seeing, but we couldn't clearly identify where the tongue activation was. Now, as far as the speech, language function is predominantly left-sided dominance, and you definitely see activation posterior to the enhancing component, but there's also activation in those areas of T2 hyperintensity. So this is where I love what Dr. Q and Savsevitz do. They take this as an initial planning guide and then still do an intraoperative awake to be more specific. I think that's the right way to apply functional MRI, how we do it here.
Thank you. A DTI scan was also done because of the location of the lesion. And a DTI scan is done so as to map the loquent white matter tracts. And we can see that the lesion is not affecting any of these tracts. Dr. Sukhvinder, would you like to add something?
Yeah, this is a little bit more difficult with DTI. You know, you're getting edema and you don't know if you're affecting the fractional anisotropy of the tracts. But this does give you some indication, at least that most of the IFOF is preserved there.
Thank you. So next, the neurophysiological examination was done by Dr. Savsevitz. A baseline cognitive evaluation was performed, and he had some abnormality in his frontal subcortical testing, especially visual memory and verbal fluency. He also had some issues in word finding and naming. This does not seem to be because of the hyperintense focus that we saw in the MRI, but it could be micro invasion of the tumor into the subcortical regions. Now let's get into some of the anatomy to better understand why certain language tests were done. So this is the superior temporal gyrus. And in the middle of the superior temporal gyrus, this part is involved in decoding phonological data that we receive from the external environment. And the posterior part is associated with retrieving phonological data so that we can create speech. So to test these two centers, he asked the patient to perform a simple yes or no sentence like "do monkeys fly?" to which the patient replied C as in yes or no, or he asked the patient to complete sentences. I think Dr. Savsevitz is not online. So, all right. So after all of these testings and the images, we had 3 differential diagnoses. Highest on the list is a high-grade glioma. Second is secondary malignancy, for which the patient was thoroughly worked up. He got CT of abdomen, pelvis to rule out any malignancy. And for lymphoma, his CBC did not indicate that. So assessment and plan, we had a 71-year-old male with focal seizure and a brain lesion, for which we decided to do an awake craniotomy with functional mapping. The goals of the surgery was to get tissue for diagnosis, maximal safe resection, and to avoid any neurological deficit. The potential risks and complications of the procedure are a speech deficit, infection of the skin, meningitis, stroke, hemorrhage, damage to neurological structures, CSF leak through the skin incision, and death. So left away craniotomy for tumor resection, along with intraoperative neurophysiological mapping. So a skin incision was made, and the surgeon begins by creating a musculocutaneous flap. This musculocutaneous flap is retracted forward, and the muscle is dissected off the skull. Next step is to create a burr hole, and the dura is separated off. Next, the craniotomy was made.
I just comment right
And
now,
the dura was
beautiful craniotomy by JP and very tailored just to what we need, all right? You know, we needed to go after that lesion. Dominant hemisphere, we try to avoid, in this case, we like to do a temporal lobectomy, but the stakes are high, highly functional vision. He's got a lot of his faculties very well preserved. So you can keep the film rolling, Ruchika, so that way. And I have David right behind me, Dr. Sapsevich. You can see him. He's logging in, so it's going to be perfect when he comes in for the mapping portion. But yes, so Taylor, and there's JP doing a beautiful job opening and making sure that we use the navigation system, all the images that we get with neuroradiology, and of course, a very thorough evaluation preoperatively to be able to tailor this. So here we are. And JP is bringing the ultrasound right there. So keep going, Ruchika.
So here we can see this hyper intense lesion. And we also find that the lesion is
the whole time. I mean, what we didn't hear right there is the fact that as I am doing this, David is continuing to map the patient. And this is something that is a concept that it is not really, well either accepted or used in the literature. There are a lot of functional neurosurgeons, Defoe being one of them. They map and then they put the patient to sleep. They map the cortex, and then, of course, their concept is that you do a gross total resection, and only the cortex is important. For us, it's also not only the neurons, but also the white matter tracts. And we are monitoring that just by the pressure that we're putting, by the tests that are being done. And every now and then, Dave, Dr. Sapsa, you've been in the area. Hold on, guys. Just something is, the patient is not getting, this is moving very fast, and he's giving me feedback, and you hear it. And there's a lot of activity, and this is why we can do these cases. That case probably was done in about 35 to 40 minutes.
Thank you. So after dissection, an ultrasound was done in which we saw the cavity is clear. Next, the cavity is packed. The dura is sutured. And DuraGen is placed to secure the resection site. The bone flap is now screwed back on. The muscle is sutured. Next is suturing of fascia.
In those small details that are not so small, that I think JP illustrated the importance. What he just did right there with the muscle, the way that he collected that tissue, will maximize the chances that that healing, that wound, when you see it in about a month or 2 months, is going to be almost perfect. And that scar is going to be barely visible, because the patient is also going to need to get more therapy, remember, after this. But those are not small details. Sometimes we just focus on the surgery and we forget that all these other things are equally important.
The other point I just want to bring up real quick is I think we've all come to appreciate the incredible individual variability in how eloquence is represented in the brain. I did a case, I think it was with you, Dr. Q, not too long ago, same kind of area where we were stimulating and we got, again, this pure word deafness phenomena where the patient couldn't understand any spoken speech. And we obviously avoided that during surgery. Whereas in this case, we had a lot of clear functioning. So again, you can't just assume a one-to-one relationship between anatomy and function in these cases. cases. It's very complex.
Beautifully said. Beautifully said. And one day we'll present that case as well. And then one day we're going to put them all together in a publication where we look at maps of the brain.
Thank you. So in the pathology report, we had a left brain tumor biopsy, and there was variable immunoreactivity with subset of tumor cells. The tumor cells had a high mitotic activity, vascular proliferation, and thrombosis, and this was in line with the diagnosis of glioblastoma, IDH wild type, WHO grade 4. The tumor was negative for MGMT promoter methylation. These are the post-operative MRIs. Dr. Sukhwinder, would you like to comment on this?
Yeah, no, this is a great resection. I think one of the things that you don't appreciate on this is this is a post-contrast T1, and you see that area of what looks like enhancement, but that's mostly normal post-operative changes. If you compare that with the non-contrast T1, none of that's there as it is. So you're really important to get that immediate post-op. We do a great job of getting these post-op images within 24, 48 hours before the granulation tissue sets up, so that we can monitor these patients as they go through radiation and treatment to evaluate for progression.
Beautiful trick by Johnny that he tells you. So normally the pituitary is the same. You have to look, and the pituitary actually is inverted. It's the other way around. So you got to look at the T1, with contrast, and the T1 without contrast, and that's when you realize, those are both products. And if you remember from the mnemonics, itty bitty baby doodoo, you realize that blood is going to be bright right around this time. Right. So, and very, 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 very good trick, Johnny. Thank you.
So here we have a comparison of pre and post resection MRI. This is a pre-op axial cut T1 post-gadolinium and a post-op axial cut T1 post-gadolinium. And here we can see that this is the hyperintense focus. This was the lesion. And here we see that the lesion is not there anymore. Post-operative course. Now, the operation was uneventful and the patient was transferred to ICU without any neurological deficits. Serial neuroexaminations were performed. On post-operative day 1, the patient had an episode of focal seizure, and this focal seizure was characterized by confusion and receptive aphasia, which subsequently resolved. He was discharged on post-operative day 3 on Keppra, Vimpat, and a steroid wean. Follow-up. The patient was followed up after 2 weeks of his operation, and his family met with Dr. Quinones and Dr. Almeida 2 weeks after his surgery to remove his stitches. They recommended consultation with neurology and radiation oncology team for further workup. And due to the pathology and nature of the lesion, he was advised standard of care. He met with Dr. Wendy Sherman, who also recommended standard of care, which consists of radiation therapy with concurrent temozolomide, followed by 6 months of adjuvant temozolomide. She'll be following the patient for seizure activity. Dr. Sherman, is she online? No, I think, all right. And then the patient met with Dr. Trefoletti, and he explained the chemoradiation options. Thank you.
Well, and I don't know, once again, if we have anybody from radiation oncology or neuro-oncology here that we call upon Dr. Trefoletti or Dr. Sherman.
But bottom line, out of office today.
They're this week. Bottom line, go back, and I'm going to ask Johnny, and I'm going to ask Dr. Mead to comment in this right here. The postoperative MRI, you had it right there, the T2, because this is a good there right there, perfect. Actually, the T2, the other one that you had, it was okay. After this one, where you compare. Go to that one right there. Stay right there. So as you can see, ideally, in the ideal world, I like to do a supramarginal resection. I just take the area of contrast. But in this case, the patient is highly functional. He's got a lot of pathways, vision. There's a lot of function. And Johnny can tell you all about it, do a whole 2-hour lecture in the temporal lobe, especially dominant hemisphere. Normally you could potentially take the anterior 4 centimeters in the dominant hemisphere and give the patient a temporal lobectomy, supramarginal resection. In this case, I felt very nervous. You can see where the lesion is located. We know from neuropsychology and from functional MRI, there's a lot of function in those regions. So we didn't do it, but you have a lot of edema, a lot of, well, what we think is edema, but it may actually be infiltrative cancer cells already. So I'm going to ask Johnny to comment as to what neuroradiology paradigms we may have today, or we may be developing in the future to be able to tell the difference. And then I'm going to ask Paola to comment as to her hypothesis as to what may be going on in these areas. So Johnny, you want to comment in my thoughts and my questions?
Yeah, no. One of the things that's been used in the past is diffusion kurtosis to see what's edema. What I do is I take, with some of our software that we're able to do, is overlay the images pre-op, post-op, and then also overlay the T2 with the flare. And it's really difficult to identify which areas are just post-operative or vasogenic edema and which areas are microscopic tumor cells. So this is an area that is really has a lot of potential for growth. I mean, we go through this all the time. Every day we read scans, 3 months post-op, 6 months post-op, chemo, radiation. Is this progression? Is it pseudo progression? Is it edema? And, all these things make a real difference, because you got to think these patients have a limited time left and they're anxious, from one scan to the next. And everything that we say is, oh, we think it's progression. Well, the whole family, I don't know if any one of you have had family that's had cancer. Whenever they're going to get their follow-up scans, the whole family's calling, praying, so all these things matter. So if you can give them some kind of idea where you're at, it's worthwhile. We've taken a lot of nuclear medicine techniques with FDG PET and now F18, and it's still not there. We're still not there. We still don't have a good way of identifying progression and pseudo progression. And so one of the things that I'll do is I try to be definitive in saying it's progression or just radiation effect. And what I'll do when I look at these scans is that I'll look at the enhancing portion on the post, 6 months down the road, the enhancing portion, the T2 portion, and then I'll look at how they're doing clinically. I'll call up Dr. Sherman and say, well, how are they doing? What are you feeling? I need to know what medications they've been on, what chemo they've been on. Are they on steroids? Because it takes a whole holistic picture to take care of this patient. So that's the best I have now. Unfortunately, there's not anything, but I think we're going to get better. There's no doubt about it. I mean, there will be something that we'll be able to map what's actual tumor and what's actual edema.
And I think that's already, as you know, your group, Neurology, they already have an artificial intelligence group working with us, with Diogo, with Paola. We're collecting tissues from this region. So now I link it to Paola as to the experiments that we have going on, the data we're collecting from the OR. And Paola, how is that helping us? And then what do you think is going on in this region right here? Go for it.
Thank you, Dr. Q. Yeah, so I was talking to Dr. Q because my projects are related to how we can use GBM migration at a cellular level and correlate with patient prognosis. And we have been doing some microfluidic studies that indicate that cell migration, like aggressive migration, is directly correlated with a poor prognosis. And in another project with Dr. Schiaparelli, we study the sodium potassium chloride channel and how GBM cells change volume in order to migrate. So my hypothesis, and that is what I was talking to Dr. Q, is that what happens with the tumors that have marked edema is like the volume changes with these ion channels. Is it higher? Is it lower? Does it correlate with migration? there are several studies, and it's actually a hot topic in GBM, that steroids increase migration. So it could be related to the edema or by a direct effect on the cells. So I was talking to Dr. Q that maybe an increased edema could be related to like maybe increase or decrease migration. I don't know at this point. So it would be interesting to correlate the imaging with the in vitro studies that we have been getting and doing in the lab.
And I think that the other mechanism, some of the molecular engines that we studied in our labs, of course, sodium potassium chloride channel, we published some really amazing papers. The other one is the sodium hydrogen exchanger. You know,
Yeah.
NHE9, particular NHE6, you know, some of the ones that we have a paper that we just published in PNAS a couple of months ago. So possibilities right here. And then correlating this to imaging, you know, back, you know, with Johnny and Eric and all the team, Vivek, I mean, there's tremendous interest right there, you know, with Dr. Wang now also from artificial intelligence and a lot of, you know, data, because we are doing, I don't know, 100, 200 of these patients a year. Suddenly in a year, you have 1,000 patients, you have amazing data that we can correlate. So thank you. And Elir, I see your comment. You want to just wrap it up with that comment right there, Elir, please.
Here we go.
Yeah.
Paula, those are excellent points, and I love your guys' presentation. From the world of analgesia and anesthesia, we do know that there's a lot of evidence, especially in vitro, where opioids are actually promoting angiogenesis in tumors. Are you guys collecting any data on that correlate? Because we do know, for example, the cases that we do under general anesthesia, they will be exposed to more anesthetics, more opioids versus some of our wakes. I think that's fertile ground if you guys are able to collect biomarkers for tumor migration and angiogenesis and markers of that nature.
Well, this is perfect. Then I'm going to ask one last comment by Dr. Otamendi, who is actually leading that precise study with you and with the Gruenbaums and collecting prospectively data in our awake versus asleep craniotomies. Andrea, do you want to comment on what we're doing from that perspective?
Yeah, we're also trying to do it retrospective, and we are going to start doing it prospectively. And we're very excited because there's not much data published on brain tumors, but many data from other type of tumors. So it will be very exciting to see the results and to correlate at the cellular level with the OR and the outcomes of the patients.
So Elir, to be brief, so as you know, every time that we take a patient, just like this morning or yesterday, you were with us, the patient goes to pre-op, we collect blood. Patients go into the operating room, we collect blood. We collect the tissue. We collect tissue from different regions. So, you know, most people know that the biobank that we have, I personally spend over $600,000 a year to maintain it between FTEs, between paying for the tissue collection and all that kind of stuff. But that's created a tissue collection that we had about 2,000 samples at Johns Hopkins with patient data, and now about over 1,000 samples here at the Mayo Clinic. So suddenly we have a wealth of knowledge that we can look back retrospectively and trying to understand what happened to some of the laboratory markers. What happened to the white blood count, what happened to the differential of the white blood count before, during, and after surgery. But now we can do it prospectively, and we can ask some of those precise questions that you just asked. Is the migration, is the invasion enhanced when you use a certain anesthetic? Can we control for those type of things prospectively? And I think that that is the future for us to begin to understand and be more comprehensive. But we can only do it because we work so closely with you, with the Gruenbaums, with everybody. We work so closely with Johnny and neuroradiology. So we really have an amazing team that we're assembling. So hopefully these are some of the questions that we're going to answer at the same time as we're sending the tissue to the laboratory and correlating it for migration, not only in nanopatterns, but microfluidics, you know, and transwell migrations and some of the other assays. One last comment from Dr. Mead, and then we're going to wrap it up. I'm sorry that we're running a little bit over time.
Yeah, so a low-hanging fruit to test that, I think, for Andrea and Dr. Bayaji, we get all the samples from Dr. Q and just like treat them with opioids and see angiogenesis. We have a collaboration with Dr. Dev's lab, and they they actually have a small molecule inhibitor against NRP1 that helps in angiogenesis. So we basically have the platform to test your hypothesis, Dr. Bojaji, in GBM.
Beautiful. And that actually small inhibitor, we just submitted, Deb and I, as a multiple PIR1 grant, a $3 million grant that we just got a score from the NIH that is in the fundable range. So we'll find out the final decision by the federal government in about a month from now. So beautiful. Great comments. Great. Alrighty, Andrea, what's or Diogo, what's on for the launching pad for Monday?
So Monday we'll have Dr. Michael Lumintekto from Indonesia. He'll be presenting on starting a neurosurgical service in Central Borneo, Indonesia, challenges, creativities, innovations, and ethics. And I'll be having the honor of presenting him myself. So join us Monday. Dr. I don't know if you want to have any last minute comments.
I just Michael will spend the year with us here. He's one of our former Mayo alumni, and he's amazing. He's published some beautiful papers, and he's doing great work out there in Indonesia. And we're excited to have him back, even virtually. And we're excited also to visit with him in the not too distant future. We have a chapter also for one of our for Mission Ray Foundation there, and we're planning to have a time with him, and hopefully some of you guys will be joining in one of those missionary trips. So good. Excellent. Thanks, everybody. Have a great weekend. Stay safe. I see Gabriel right there. I see Victor right there. You know, beautiful. And I know I probably missed some other people, you know, and such a great pleasure to see you guys all and to be here and to learn from each other. So, all right. Adios, chicos and chicas. Thank you, Richard.